To the clinical exome sequencing information webinar. We will be starting in just a few minutes. Thank you. Okay, then get started. Welcome to the Clinical Exome Sequencing Informational Webinar. My name is Nagme Durrani. I'm a genetic counselor at UCLA in the Department of Pediatrics. I'm also the coordinator of the Clinical Genomics Center at UCLA. I want to welcome you all to this webinar. I want to thank our sponsor, Global Genes and Syndrome without the name, to give me this opportunity to talk to you today about clinical exome sequencing. Before we proceed, please, if you have any question, direct your questions to the host, type them in, and after the presentation, I'm going to answer all the questions. Next slide, please. To give you an overview of our presentation today, we're going to talk about genome, just give you some terminology about what the genes are, so we are all on the same page about what we're going to talk about. We're going to talk about the single gene testing versus exome sequencing, indication for exome sequencing tests, the consent form, and the results. Next slide, please. This might sound like a very complicated slide, but if probably you have seen this somewhere else, or your doctor has talked to you about, genes, or maybe reading about genes and genomics, have seen some pictures like this. Basically, what we are talking about is that in all the cells that we have in our body, we have our genetics material. And if, again, you have heard about chromosomes, so chromosomes are nothing but structures that hold the genes. Basically, if you unwind a chromosome, you're going to see genes on them. If I want to give you an analogy, it's like a necklace, like a pearl necklace, that the whole necklace is the chromosome, and the pearls on the necklace are the genes. And if you unwind a gene, you're going to get to DNA, which is the building block of a gene. And again, if you unwind the DNA, you're going to get to the nucleotides, where actually the code of DNA is holding it. So the nucleotides are the building block of the DNA. And when we talk about the genes, we are talking about those instructions that help us to develop mentally and physically. You pay attention to this picture, you're going to see, these letters, T, A, C, G. These are what we call the nucleotides. And these are the codes that are read in the machinery in our body that does the instruction, again, in the instruction and how to develop mentally and physically. Next slide, please. Okay, now if someone asks you, I just gave you the answer that what does a gene does in your body, you can say that, it is the blueprint of the development. But functionally, what the gene does is that they code for proteins, meaning that this T, A, C, G, that are the letters that constitute a gene, they go and they sit, every three of them sit together and make code, and the machine comes and reads this code and make them to a protein. And these proteins, they fold and they do different functions in the body. Basically, there are two functions for the gene. One is that, it's a blueprint for development. How do they do it? They do that by making protein. If there is a change in one of these letters in any gene, it can cause problem. And this is what we do with genetic testing. What we want to find out is to see whether or not there is a change in any of these letters that can cause problem. Okay, next, please. Now, let's get to some terms that I'm going to use throughout this presentation, so I do not go and define them every time. When we talk about a variant, we talked about any change in the sequence of a gene. Again, it's any change in one of those letters. This is called a variant. We talk about a mutation. It's basically a variant that causes a disease. This is what the geneticists refer to. As you hear the term mutation a lot of times, but people usually use them interchangeably with variant, but these are not the same. A mutation is a disease-causing variant. A phenotype is how a gene is manifested, how a gene expresses itself. So if someone is short, that's a phenotype. If someone is tall, that's a phenotype. If someone has a seizure, has developmental delay, that's a phenotype. So again, you're going to hear these terms throughout the presentation, and we now understand, what they mean. Next slide, please. I'm not sure. I do not know all the families who are on this call, but I'm thinking that many of you have been to many physicians, maybe many geneticists, maybe, or even one geneticist, and you have gone through a lot of search to find out what is the reason behind the problems that your child or yourself has. Um, uh, Probably some of you have had genetic testing before, and your doctor has ordered, a test for a single single gene, one particular gene, to find out whether or not there is a change or a mutation in that gene that can explain the disorder. Now, there's a difference between exome sequencing and a single gene testing. Next slide, please. Talk about single gene testing. A good analogy for it is that you have a bookcase in your room. You have a few books in them. They're good. They're very informational. You can open one book and read and get a lot of information. But if you not find the information that you want in those books, that's it. You just have a few books in them. It's limited. Next slide, please. About Exome, it's like you're talking about the Library of Congress. This is actually the library in Ireland, Edinburgh, and you can see that how many books we are talking about. When we talk about exome sequencing, we're talking about 20,000 genes in the body that we're going to analyze at the same time. So there is a big difference between single gene testing and exome sequencing, and that's the amount of the gene or the number of the genes that we're going to analyze by exome sequencing that's not doable by doing one single gene testing. You can do it, but you have to go and sequence every single gene, and you have to do this 20,000 times. With this test, you're looking at all the genes at the same time. Slide, please. Before we get to exome sequencing, I want to explain one other part, about genomes and genes. This picture is a traded, I should say, picture of a gene. Gene has different parts. Any gene has different parts. Part that codes for the protein. You remember we were saying that the nucleotides, every three of them sit together and make a protein. Those that make the protein are sitting in those places that are called exons. And the exons in the body is called exome, just like genome, exon, exome. The parts in the middle that they do not do anything, or at least we do not know exactly what they do, are called introns. The other parts of the gene that it has been not shown in this picture that are also important. They can probably maybe turn off the gene or turn on the gene, but the parts that we are doing the analysis during exome sequencing is the exon, and I tell you why. First, we do not have a lot of information about introns and other parts of the genes. The thing is that we know that mutation, or as I explained it to you, variants that cause the disease, 85% of them happen in exons. So there is a very good justification of going and looking at exons because we have good information about them. One thing that you have to understand is that these exons in the body constitute only 1% of your genome. So of all genetics material that you have in your body, only 1% of it is the exon. But because 85% of the mutations happen in exon, there is this justification to go and look at exons. In few years, we're going to have a test that is going to be called whole genome sequencing. It's going to examine not only the exons but also the introns. But I have to tell you that the interpretation of that test is going to be very, very difficult because, as I told you, we do not know enough about the intron parts and about the other portions of the genes. So it's going to be very hard if we see a change in them to interpret them to see whether or not they're causing a disease. Next slide, please. Okay, this is a schematic of what exome sequencing is. Please do not worry about what is written on this. It's just some genetic jargon, and it's not important. But just what I wanted to show you is that the way that they do this test is that they take the DNA, they take the exon out of the DNA, all the exons, and with a machine, a specific machine, they go and read all the letters in the exons. And that's the first part of the test. This is the sequencing part of the test. Next slide, please. Part that is actually very complicated is the bioinformatic part. The bioinformatic part is that now that we have the DNA sequence or the exome sequence from the patient, what do we do with that? We have to compare this to many different databases that have information about genetic diseases, about those benign variants, those controlled DNAs. These are DNAs that we know that there is no disease in them. We compare them to very different databases. We come up with a list of genes that we think are associated with the symptoms or the phenotype that the patient has. And we go and analyze those genes one by one to see if there is change within them that can explain the symptoms, or the phenotype, or the underlying cause of the disorder that the patient has. Again, this is an oversimplification of the process. It is very complicated, and I just want you to have an understanding of what is going on when we talk about exome sequencing. It's a little bit different than, again, single gene sequencing, and it is more complicated and more involved. Next slide, please. So people ask, okay, this exome sequencing is great, wonderful. When do we use this test? Do we just send it for all patients? No. Like everything else, you have to have indications. You have to know why you're sending this test and when is it that it is recommended. American College of Medical Genetics is the entity that generates these guidelines for geneticists, and they have this recommendation for the geneticists on when to use this test. The first one says that no clinical test available for the targeted gene. What does that mean? This means that your geneticist sees you and suspects, or your doctor. I'm saying geneticist just because I work in genetics, but your physician sees you and says, "Oh, it seems that this is a genetic disorder," and he or she goes and does a literature search, and finds, for example, a paper that has reported another patient that looks very similar to the patient that he has, or you who have been his or her patient, and he tries to see that whether or not they have done any genetic testing, and it says, yeah, there is a research, they have found a gene, and they say that this patient has a change or a mutation in a certain gene, and then he tries to find out whether or not there is a clinical test available for this gene. Remember that there is a big difference between clinical testing and research testing. When you do a research test and you test a patient, on the research basis, the lab that does the testing does not have the intrinsic control or all those standardization that a laboratory that does a test on the clinical basis does not have the same control. I'm sorry, I'm going around. They do not have the same standardization that a laboratory that does a human clinical test, available. So it is very important that when you do human test, and if you want to give the results to the patient, you do in a lab that has standardization. approved this on federal and state level. So the clinician looks at this gene and tries to find out whether or not there is a laboratory that does this test, and it does not find anything. Exome sequencing is a good test for that because it takes some time for the research lab when they find a gene to make it to clinical lab. So exome sequencing, because it looks at everything and it's a clear approved, there are laboratories that can do this on the clinical basis. It is a good test to be offered to the patient. Second one is this available tests have not yielded any result. Again, many of you, I'm not sure, but we have a lot of patients that we have followed up for 10, 15 years, and we have exhausted all the genetic testing available to us, and we do not have any results. And I'm going to show you an example of that. So there is a possibility that there is a gene that we are not thinking about. So exome sequencing, again, because it is looking at all the genes, it is a very good choice for this patient. The last one says that a phenotype caused by mutation in different genes. What does that mean? It means that someone has a headache. You can imagine that this person has a headache because she or he has a cold. She has a headache because she might have a brain tumor. She has a headache because she has a migraine. So different diseases can cause the same symptom. This is exactly the same thing for genetic disorders. A patient might have seizures, and different genes, mutations in different genes can cause seizures. So instead, again, of going and testing one gene and one after another, it is a good thing that you test everything at the same time, and that's why you can offer exome sequencing to the patient. Next slide, please. So what happens? What is it that you have to do as a patient? The test definitely needs a pre-test evaluation. What is the goal? The goal is to see whether or not the patient is a candidate for whole exome sequencing. Whole exome sequencing is the same thing as clinical exome sequencing. And some laboratories use whole exome sequencing and some use clinical exome sequencing. So and the goal, again, is to see whether or not a patient is a candidate for exome sequencing. The process that the physician goes through and the patient goes through is that there should be a review of medical records. There should be a review of genetic tests performed. The doctor has to do a medical history, take a good medical history, a very good family history, and I cannot tell you how important this part is to the interpretation of the test. It's not only good for the doctor, but also for the laboratory. We request medical records from the physician because at the time that we want to do the data analysis, and we have a board of experts, clinical geneticists and molecular geneticists and cytogeneticists, all gathered in one room, look at the data from the DNA of a patient, and we put it together based on the medical and family history that we have. So this is extremely, extremely important that you see your doctor and the doctor does a good medical and family history and send it to us for the interpretation of the test. Next slide, please. I told you I'm going to show you an example of when clinical exome sequencing is indicated. I have changed a little bit of the history to protect the privacy of the patient, but this is a real case. So we had this 17-year-old young woman who had the history of sudden cardiac arrest. She just collapsed, and she was referred to genetics for evaluation. When we took the history, there was really nothing in the history that could give us a clue of what gene we have to look at. And whether or not this is even genetic. And I mean that, when you just focus on the patient, it was just, history of chest pain 2-3 times. There was no history of palpitation, headaches, something that could, again, clue you into a good diagnosis. diagnosis. With all this testing, like electrocardiograms, echocardiograms, take pictures of the head CT scan, nothing that again could help us to make a diagnosis. When we looked at the family history, next slide, please. We saw this family history that it is worrisome. You can see that the father had hypertension. Is only in his early 40s. There are different paternal uncle aunts that have some kind of heart problem, and there is a paternal uncle that had heart attack. So you do not need to be a geneticist or genetic counselor to see that, okay, I think there is something genetic going on in here, right? So when I was talking about the diagnosis, I was talking about the diagnosis that should we worry about the diagnosis that is genetic, or is something that is something physical that does not have a genetic basis. So do we have to go and do any genetic testing on the patient? And yes, because of this family history, we went ahead and did a lot of genetic testing. Next slide, please. The list of all the genes that one by one we tested in this patient. You can see how time consuming it was. You can see that how expensive it was. And everything came back normal. Now, do you want to do exome sequencing in this patient? Yes, because since we have seen this patient, there are many more genes known that can cause heart problems, and there are family members who are at risk. In this family, she has young siblings that might benefit from the test results, and we can do a better management if we have an underlying cause for her. So yes, she is a good candidate for whole exome sequencing. And again, my guess is that although I do not know all the audience, that many of you might be in the same picture, going, having had many tests and nothing has yielded any results, and now you're a candidate for you or your child is a candidate for whole exome sequencing. Next slide, please. Okay, so your doctor decides that you're a good candidate for exome sequencing. What is next? There's a lot of questions around exome sequencing, like, what is it that we have to report? How do we report these things? A lot of discussions, a lot of debates, within the genetics community. And, for some there is consensus, for some there is no consensus, but there is consensus about one thing. Everybody, all geneticists, genetic counselors, they all agree that if you want to do this test, it should be done in the context of an informed consent. What does that mean? It means that your physician, next slide please, has to go through the consent with you and explain this test to you. So what I'm going to talk about in the next few slides is about the consent, but please remember that this is not going to replace the consent that you have to have with your physician sitting and talking about this test and having your questions answered. No laboratory in the U.S. accepts a sample without a consent, and the consent is signed by the patient and the physician. The physician has to go through the benefits, limitations, and risks of the test. You should have time to read the consent and have your questions answered. And please keep a copy of the signed consent for yourself for future references. Next slide, please. Go over the points that the physician is going to discuss with you in the consent. The first one is that why are we doing this test? I'm sure that you all know what we are doing. They're doing this test, but I'm bringing this up because the best way of doing this test is what we call a trio. We get samples from the affected person and hopefully if parents, if they're available. This is called a trio sequencing. We are doing this test only for the affected person. Since the parents come back and ask me, okay, you took blood from me as well. Why is it that you're not giving me a report? The test is designed to find the cause of a disability or the disease for an affected person. It's not a screening test for healthy people. is a very important part to understand, and this is in part of the consent. If the parents are also submitting blood, there is part of the consent that says that I'm not going to receive a report, and my blood is going to be used as the control from child. It's very again important to understand because this is only identification of the cause of disability in an affected person. Is that how do we do this test? When people talk about 20,000 genes, do I need to give a lot of blood? No, it's a blood test. If it's a baby, it's less than a teaspoon. If it's a child or an adult, it's 3 to 7 milliliters, which is about 1 teaspoon. Next slide, please. This, like any other test, has some limitations. You remember that we were talking about introns and exons? I told you that we are going to analyze only the exons. So is there a possibility that there is a change in one of those letters in the parts that are not the exons, the introns or, the other regions of the gene? Absolutely. It's true that we do not have good information about those parts, but it does not mean that if there is a change in the other parts, it do not cause a disease. So if there is a mutation in other part of the genes, we cannot find out with this test. This is one limitation. The first one that I skipped, it says triple repeats. You remember we were talking about the code being a code, 3 nucleotides sitting together and making code. Sometimes this triple code gets repeated over and over. For example, you have a code that is CTG. This CTG gets repeated like 10 times, like 100 times, like 300 times. This test is not designed to find this type of mutation. This is a type of mutation. It's called triple repeat mutation. Some disorders, like you might have heard of Fragile X, it's a disorder that causes developmental delay and intellectual disability, mostly in males, or Huntington disease that causes neurological disorder in an affected person, and are triple repeat mutations. The physician suspect that one of these disorders is involved, you cannot really send for this test because this test is not designed to pick up those type of mutations. So they're the limitation of the test. Second one that I think is more important than the first two that I explained is that our knowledge is limited. We do not know about everything. We do not know about all the genes, all the functions of the genes. So I'm going to tell you about instances that we might find something that we are uncertain about it, and we're going to call them variant of uncertain clinical significance. Next slide, please. Risk for the test. I'm going to get to the variant of unclinical significance in a bit in the next slide. Let me go over the risks with you. Sometimes when we find a variant of unclinical significance, we have to go test other family members to clarify the results, even healthy family members, to see whether or not they have this variant, or is it only affected people who have this variant. We can stumble on things that are not related to the clinical concern that the patient has. Imagine that someone has developmental delay and now we find out about a change in a cancer gene. These are called incidental findings, and I'm going to get into this as well. And genetic disorders that there is no treatment for it. We can find out about biological relationship that, the father is not the father, the mother is not the mother. All these can create anxiety and psychological distress for the patient. That's why we need the physician to discuss this risk with the patient and make sure that they understand that what can come out, from this test. Next, please. How long does it take to get the results? 3 to 4 months, because it's a lengthy process, as I explained to you. What will be reported? There are 3 main things that will be reported. One is that you find a mutation that can explain the disorder, period. Wonderful. That is what we are doing the test, and you find it out. Second one is the variant of uncertain or non-clinical significance. It means that we do not really know at the time that we are doing the test what they mean. It does not mean that they are causing the disease. It does not mean that they're benign. It's just that we do not really know what they mean. So, and I'm going to explain to you in the next slide what is it that we can do about them. And incidental findings that, again, I'm going to get to it in a bit. Next slide. So, once you have a result and we send it to the doctor, you still need to go and make an appointment and see your doctor, even if your test is negative. And I strongly recommend that you do that. If you get the report that is generated, it's like 5-6 pages, that is a lot of genetic jargons that it's not comprehensible if you do not talk to someone who can go over this step by step and explain to you what is happening in it. So even if it's a test is negative, make an appointment and go and see your doctor. And please remember that this test had limitation, and because it came back negative, it does not mean that the condition that you or your child has, it's not genetic. Okay, it's not 100% ruling out that it's not genetic. There's always possibility that you have another child and the other child is affected. A negative result does not rule out that the possibility of a genetic disorder. Now, about positive result. That we might find a mutation that is related to the clinical concern. Wonderful. What does the physician do? It goes through the risk counseling for you. If you want, future pregnancy, they can give you options about prenatal testing, reproductive option. They talk about the disorder. They talk about management, prognosis. They can give you resources for the family. It's very straightforward genetic counseling. If they find a variant of clinical significance, that's a little bit tricky, because what is it that we can do? The doctor, might do further testing, like, there is imaging, some other biochemical tests that they can do to find out whether or not this is significant. Sometimes they might test other family members. Sometimes they might see if there is a group that is doing research on that gene, and is there any further information that they have, or if the patient is interested to join that, to participate in the research that they have. Or sometimes you have just to wait. Just to sit and wait and see, revisit the results, in 6 months, and to see if there is more literature about it that can explain whether or not this is benign or this is disease-causing. Next slide, please. What are incidental findings? There's a lot of discussions about incidental findings. Basically, incidental findings refer to results that they do not relate to the indication for ordering the test. Again, I gave you an example. Someone comes for developmental delay seizures, and you find out about a change that is causing cancer. This is incidental finding. And you stumble on it. It's not that you're going and looking to see if the patient has cancer. It's just when you're analyzing the test, you say, oops, the patient also has this change. Next slide, please. The American College of Medical Genetics has recommended that they have come up with 56 genes that basically they have this criteria that they recommend that we go ahead and report them if we find an incidental finding in them. There is preventive measuring them. It's that they're medically actionable. There is something you can do about them. Like there's some forms of colon cancer that at 8, even as young as 8 years of age, you can have colonoscopy and to see whether or not a child has polyps. So that's something that you can prevent, and that's one of the genes that's listed here in the list that they have given. These are late onset disorders, meaning that they happen later in life, and this change, it should be a mutation. You remember that I told you there is a difference between variant and mutation? For sure, based on the literature and everything, all the databases that's available to you, that this is disease-causing. So it's the VUS, it's not a variant of uncertain clinical significance. It's We know that this causes a disease, and that's why we can report them. And so, what American College of Medical Genetics is recommending is that the physicians should be able to provide pre and post-test counseling for this incidental finding, and they should be able to interpret it, and they should refer the patients for genetic counseling. Next slide, please. The UCLA policy on reporting incidental finding is that when you see our consent, we have an option, an opt-in or opt-out option that it says very clearly, yes, I want to have incidental findings. No, I do not want to have incidental findings. And you can imagine why we have the opt-out, because it can create a lot of distress for families. You know, something happening 40 years from now, a young child, you know, finding that it has a gene in breast cancer. What are you going to do in a 2-year-old that, you know, has a mutation in breast cancer? Nothing. And some family might not want to even know about this information. So please think about it when your physician discusses this with you, and see what is it that you want to do about it. Again, I put it medically actionable. It just means that, you know, we're going to report those mutations that there is something that you can do about them. There are some preventive measures about them. Next slide, please. To summarize, exome sequencing is a very, very powerful diagnostic tool for geneticists. It is highly recommended that the patient has a pre-test and counseling and goes through the consent process. People think that, you know, the old-fashioned medical and family history things, you know, should not happen. No, that's not the case. It is still very, very essential that you see your doctor and they go through the medical and family histories. It's not this test does not replace that you just get a sample of blood and you put it in the machine, and from the other side you get the results. It doesn't work that way. It works closely with medical and family histories that the physician sends to us, and clinical correlation is very necessary to assess whether or not a finding is causal, causing the disease, or it is not causal, it is benign, for the future, especially when variants of uncertain clinical significance are detected, and your physician has to discuss this in detail with you and see what would be the plan for follow-up on those variant of uncertain clinical significance. And with this, I end. If you have further questions about this, you can to this website. They have a lot of information, and again, I thank you for attending this webinar, and I'm happy to answer questions that you have. The first question I answered, it says, is there a difference between exome and whole exome? No, exome and whole exome, clinical exome, they're all the same. And I am not seeing anything else. If you have anything, please send them in, and we're going to wait a couple minutes. Do you report any incidental outside of? Yes. If again there is the question is, do you report any incidentals outside of the 56? Yes, we do report if again the gene is something that is medically actionable. I cannot emphasize this enough. If there is something that something medically can be done about it, yes, we do report. Any questions? Okay. We've got a few minutes. the next question that came in: can we still get valid results taking blood from mother and child if parent or father is not involved? Yes, even when we do only on the child, we can get valid results. It's not about validity of the results. It's not as conclusive. So if you have, it's better to have even one parent. Again, it would be great if we have both parents, but even if we have one parent, it's going to be then only testing the child. And this one, what is the success rate of finding a cause? I cannot tell you that because I do not have a number. The rate that we have at UCLA, we have been successful in finding results, and this is for developmental delay indication, about 40%. 35 to 40%, which is pretty high, I should tell you. But it depends on the disorder. It depends on what you know about the gene and all that. And we do not have, and it's not UCLA, we do not have good numbers about this anyway, this time at least. Um, Leaving one child tested, if a mutation comes back, would it be reasonable to test the other child for that specific genetic mutation? Great question. Depends. Again, you have to talk to your physician, but yes, it is possible to test the other child. Again, it very much depends on the disorder. It depends on the phenotype that your other child has. But yes, it is possible to go and test any other family members for that specific mutation, and the cost is much less, and it is visible. Um, the results will be sent to the physician only, or will be also receive a copy? Does it all go through the doctor? Yes, the laboratory is going to send the results only to the physician. But I'm a genetic counselor. I see patients all the time, and I go over the results with them, and I always give them a copy. You can request from your physician to have a copy, and I highly recommend that you do so, even if it's negative, to have a file for yourself and have a copy of this test results. The test then be ran if there are similar physical issues with the second child. Would the test then be ran if there are similar physical? If I'm understanding your question correctly, I'm reading it again. Would the test then be ran if there are similar physical issues with the second child? Related to your question. We're not going to do an exome on the other child. We're going to go and test the other child for that specific change that we find in the first child. Imagine that you have a book and you know exactly in what page, what letter, what line, what word, and what letter has changed in that book. You do not need to read the book again. You just go and open it to that page, and you go and find that letter and test that letter. That's it. That's what you can do if you have another child affected. We have 4 more questions. When will we receive notice about talking with our PCP to receive testing? That cannot give you information. I think you have to contact either SWANS, I think, or Global Genes. I think it's SWANS that has to give you that information. I do not know how this has been set up, but if you have qualified, for this, and you have received something, you can make an appointment and go and talk to your physician. Still waiting for more questions. Um, okay, I have actually a message that you should be hearing from Amy from Swan once they have sent in all their initial paperwork that Swan requested. So you should be hearing from from Amy from Swan, when you sent all your paperwork that they have requested. Done it, so please send your paperwork to Swan. Genetic material be stored in a data bank for further medical use advancement. Data will be stored, but I'm sure if you mean that you go back and look at them, yes, we can look back at them. Internally, they might be used to improve at the time that we are doing the testing, to improve the quality of this test. But if there is any research, we won't do that without your permission. Someone has to contact you and go over the new consent with you and say that would you want to participate in the research and so forth. But we will not be using it for any research, if that's your question. Another question is that my son had a microarray analysis. What is the difference between this and whole exome sequencing? Microarray analysis is you look at to see if there is deletion or duplication of genetic material. Okay, so the difference is that with whole exome sequencing, you go to the gene level. Okay, so it's like with a microarray, you are looking, from the moon at Earth, and you kind of can see that the Earth is in place and the continents are in place and all that. But when you are talking about whole exome sequencing, is that you are on the Earth You go to an individual house and you ring out and you go see if a person is in the house. The difference is that. So that's a little bit more general looking at the genome, and this is more detailed. Macroarray analysis is good for some indications, and whole exome sequencing is good for other indications. If they discover a mutation through the testing that has never been seen before, okay, that's exactly what I'm talking about, variant of uncertain clinical significance. So you can see a mutation. It looks like a mutation. It is, based on the criteria that they have, they know that it is damaging to the protein. But because it has not been reported before, they cannot really go see that this is disease causing, or the medical term for it is pathogenic. They cannot call it a pathogenic mutation. They call it a VUS, or variant of uncertain clinical significance. And until someone else reports on that, or again, there is something else that you can do to determine whether or not this is causative, you leave it as a variant of uncertain clinical significance. Certain clinical significance, is that the same as a novel variant? Novel variant means that you haven't seen it before, but when they have to categorize it, they have to call it a variant of uncertain clinical significance. And when you get the results, it explains it. It says that this has never been seen. It has not been associated with the human disease, or only they have seen it in animal models. It explains, the results explains, what is it that they found. But at the beginning, when they have to give the results, they have to call it something. They do not call it the novel variant. They call it the novel variant of uncertain clinical significance, if you put it that way, because they cannot give an explanation whether or not it's causing the symptoms of that patient. That's why they call it uncertain clinical significance. Any questions? It seems that there is no further question. I want to thank everyone for attending this webinar. I hope it has answered some of your questions. And again, I want to thank the sponsor again for giving me this opportunity to talk to you. Thank you very much and goodbye.